Welcome and hello, everyone. Thanks for joining us today for this GADA webinar focusing on genetic testing for several life-saving reasons. This webinar will address the importance of genetic testing for heritable aortic disease, assessment and counseling, why having a genetic diagnosis is important for medical care and MAC research. And we'll also give some insights on some resources available in Canada. So I am Chrisanne Campos, the Science Director, hosting on behalf of the Genetic Aortic Disorders Association Canada. And with me, you cannot see her, but is Joanna Sanis. She's our new marketing and communications consultant, helping with this webinar. So for those, I know many of you already know, but GADA is a registered charity patient advocacy organization in Canada in service for over 36 years. We support research, education, awareness, and individuals with genetic aortic disorders. We're really proud to support the life-changing research done by the Montalcino Aortic Consortium that was co-founded in 2013. GADA funds the patient registries that are led by Dr. Dianna Milewicz in Houston. MAC, for those who don't know, is an international collaboration of multidisciplinary clinicians driving precision medicine for genetic aortic diseases using the patient registries for research studies. In fact, some of the MAC findings were considered in the new guidelines that were published for genetic aortic disease by the American Heart Association and the American College of Cardiology. So just to note that if anyone's interested in participating in MAC research, a genetic diagnosis for a heritable aortic disease is required or is really important to participate in this research. Before I can introduce our experts on this webinar, I just want to quickly go through the disclaimer that the contents of this webinar are for educational purposes only, and none of this should be taken without consulting your doctor. Also, a few housekeeping. You can reach out. You can use the Q&A box to submit your questions, or feel free to use the chat box as well. This webinar is being recorded and will be available after this session on the GADA YouTube channel. So it is a privilege again to host Dr. Dianna Milewicz once again in our webinar. Dr. Milewicz is the President George H.W. Bush Chair of Cardiovascular Medicine. She's the Division Director of Medical Genetics at the University of Texas Health Science Center at Houston. She's the Executive Chair of the Montalcino Aortic Consortium, which you're going to hear about in this webinar. And she's been the past chair and a current long-standing member of GADA's Professional Advisory Board. Thank you, Dr. Milewicz. Also with us joining Dr. Milewicz is Andrea Rideout. She's a certified genetic counselor at the Maritime Medical Genetics Service in Halifax, Nova Scotia. She's also a member of the Montalcino Aortic Consortium. Andrea, I need to read this. Andrea, she got her Master's of Science degree in genetic counseling in 2002, following which she was engaged in prenatal and psychiatric genetics research and primary care education in New York and Toronto. She returned to Halifax in 2007 and joined the Maritime Medical Genetics Services as a clinical genetic counselor in 2008. Currently, her focus is on aortopathy, connective tissue disorders, inherited cardiac diseases, and 22q11 deletion syndrome. So as with all of you registered and who have joined us today, I am looking forward to these talks and answering most of your questions that we received. So without further ado, I'll hand this over to Dr. Milewicz, who will take over this talk. Thank you, Dr. Milewicz.
Sure. Thank you for that nice introduction there, Chris Ann. I appreciate it. And I appreciate the invitation to talk at this virtual symposium. Hello, everybody. So for many years, we've been trying to identify the genes that predispose to thoracic aortic aneurysms and aortic dissection. And my work has really focused on this question because, as most of you know, an aneurysm that forms in the very first part of the aorta, either in the root down here or in the ascending part of the aorta, tends to be totally asymptomatic. And it gets bigger and bigger with time. And if it's not surgically repaired, that leads to a dissection where the blood enters the wall of the aorta and starts tearing the wall apart. And that, once the aortic dissection starts, that's a life-threatening event. And some people don't make it to the hospital and die, have sudden death due to aortic dissections. And even after they make it to the hospital, they have to do emergent repair of this part of the aorta, and there's more deaths associated with that. But if we can figure out who's at risk and follow these enlargements or aneurysms, we can go in and repair this first part of the aorta to prevent the dissections completely. So we can prevent all the deaths and disability associated with thoracic aortic disease if we can figure out who's at risk. And my work has really been to use genetics to identify individuals at risk. So for many years, we knew that since like the 1960s or 70s, we've known that you could alter just one gene out of the 20,000 or so genes that we have in the human genome. And that one change in the DNA would predispose an individual to having a very high risk for an aortic aneurysm that could progress to an aortic dissection. And we know that because the patients with Marfan syndrome, they have a variant or what we used to call a mutation in a gene called FBN1. Now we call those mutations pathogenic variants. And it causes those patients to grow tall and to have eye problems and skeletal problems. But it also confers a risk for those aortic root aneurysms that lead to type A dissections. We know how to take care of Marfan patients because we've known about Marfan syndrome, like I said, for many, many years. We know we need to treat them with beta blockers or angiotensin receptor blockers such as losartan or both drugs to slow the growth of those aneurysms. And then we can go in and repair, we can watch the aorta grow to about 5 centimeters, and that's about twice its normal diameter before we have to go in and replace the aorta in people with Marfan syndrome. And after we do that, we know that they're at a very low risk to have aneurysms or dissections elsewhere. Some of them will go on to dissect their descending aorta, but that tends to be less life-threatening than the type A dissections. And we know they tend not to go on to have brain aneurysms or aneurysms elsewhere in their body. So once we get that ascending aorta repair in a patient with Marfan syndrome, we can be fairly confident that they're going to do quite well. But now we know that there's not just that FBN1 gene in Marfan syndrome out there, that there's many other genes in the human genome that when you alter them, it confers this very high risk for thoracic aortic disease and aneurysms. And with Marfan syndrome and with most of the genes on this list here, the way that they're inherited in the family is autosomal dominant, and I assume Andrea will talk more about that in a minute. So we can use these genes. If somebody comes to us and we do genetic testing and find a variant in one of these genes, we can look at other family members and determine who's at risk. And Andrea will talk more about that in a minute. But I'm going to talk to you about how we can use these genes to really tell us how to optimally manage people with variants or mutations in these genes to prevent a bad outcome like death, disability, stroke, and other problems. And so at the top of the list, you see FBN1 up here, and then you see a whole lot of other genes. These genes here all affect a signaling pathway called TGFβ, and they make up those genes that are referred to as Loeys-Dietz syndrome. And we've known from early on, if you look at these genes in red that cause Loeys-Dietz syndrome, that patients with Loeys-Dietz, we can go in and repair the aortic root, but some of those patients are at risk to going on to have aneurysms and dissections of other arteries. And here's an example of a patient with Loeys-Dietz syndrome and a TGFβ2 mutation, where you can see here the white part is the graft, and he had aneurysms, and they're starting in that first part of the aorta, but it went on to involve the entire aorta. He had aneurysms of some of the arteries off the aorta that feed the gut and provide blood to the gut. And he also had aneurysms of the arteries that go up to our brain that provide blood to the brain. So they got big. And any of the white part is grafts where they've gone in and repaired it. So with patients with Loeys-Dietz syndrome, we know some of them will go on to have other problems with arteries elsewhere beyond that very first part of the aorta shown here. So we know after we've repaired this first part that we basically have to look from the head down to the pelvis and watch for their aneurysms. But then if you look at a different gene like ACTA2 down here, the story is very different. And instead of having to worry about aneurysms and dissection elsewhere, patients with ACTA2 mutations or pathogenic variants, we have to worry about their arteries getting blocked or closed off. And it's just associated with a few specific variants in ACTA2. And some of those variants cause the coronary arteries to get blocked off due to atherosclerosis, and that can lead to heart attacks at very young ages in these patients. And other mutations cause the arteries in the brain to be closed off or blocked or occluded, and that can lead to ischemic strokes. And the way we treat these diseases is very different from the way we treat those aneurysms and dissections in patients with Loeys-Dietz. So right away, if you have a TGFβ2 versus an ACTA2 mutation that's causing your thoracic aortic disease, there may be other problems with your arteries that we have to worry about, but it's going to be based on that actual gene. And so we knew this early on as we found those genes. But what about the aortic disease? Do we have to, how many, if you have a mutation in ACTA2 or TGFβ2, do we have to worry about you having an aneurysm in childhood? Do we have to, or can we wait to really start worrying about that until you're in adulthood? And that's what we really wanted to figure out using the Montalcino Aortic Consortium. I launched this in conjunction with the other individuals shown in red here, with the idea that if we could get aortic clinics around the world that were testing patients, families with thoracic aortic disease and individuals with thoracic aortic disease, and finding mutations in all the genes that my lab and other labs have identified, then we could use this data, put it into a big database, and be able to do very precise management to manage the disease, to really protect the patients from having a bad outcome, with the worst outcome being death. But nobody wants to have a stroke. Nobody wants to have an aneurysm in the brain rupture and also cause a stroke. So we have the ability, when we know the gene, to really precisely manage the disease, but we needed that information very rapidly. And so setting up this international patient registry called the Montalcino Aortic Consortium allowed people around the world to put that data de-identified. So there's no way to identify, you know, as you look at the papers and study the data, there's no way to figure out who that data came from. But we can look at that data and start to figure out how to manage patients with variants in different genes, and even the different variants within one gene. And I am so grateful to GADA for funding this research, and I'm very grateful for the Timmerty family for stepping up to provide that money to GADA to help fund the Montalcino Aortic Consortium. So we've had a large number of sites signed off, and I'm just going to present some of the data from the first 1,000 patients that we have in this consortium. And here we're looking at the genes in red. So these up here that affect the TGFβ signaling are Loeys-Dietz genes, TGFβ1, TGFβ2, SMAD3, and TGFβ2. And then down here are genes that affect something called smooth muscle cell contraction, and it's ACT2, MYLK, and PRKG1. So here we have 7 genes, and I'm going to start to show you the data on those 7 genes. So if we take the full 1,000 patients with variants in these genes and ask, what is the age of onset that they had an aortic event? And we defined aortic event as aneurysms requiring surgery or presenting with the type A or type B dissection. That's a dissection of the first part of the aorta or the descending aorta. And we've grouped them based on whether it's one of those Loeys-Dietz syndrome genes or whether it's a smooth muscle cell gene. And so you can see, if you look at the green versus the orange, there's no difference between smooth muscle cell genes and Loeys-Dietz genes in terms of the average age of onset. If you look at here, 50% of the people have had an event by the time they're 50. So just overall, that's what we see. You can see down here, there's a suggestion that there might be more childhood onset disease with Loeys-Dietz syndrome, but really not that much more than we see with the smooth muscle cell genes. But there's a nice little blip here in the early teens that's occurring, not a nice, but a concerning blip with the LDS genes. So we can also look a little carefully at the individual genes. And so you can see the spread between PRKG1, ACT2, and myosin light chain kinase over here, and the spread between the different TGF-beta genes over here. And I'm going to go through a bit more data, overview of the Loeys-Dietz syndrome genes and the smooth muscle genes in the next few slides. So here we have the age of onset and the number of people, the cumulative probability that somebody's going to have an event based on their age. And we have in purple, TGFβ2, in black, TGFβ1, in orange is TGFβ2, and in blue is SMAD3. And you can see there's, and I'm not going to go into all the statistics, but there's a big difference in the age of onset overall when you go from gene to gene. And we can look to see, we can see TGFβ2 is the earliest age of onset, but SMAD3 is much later. And if you look at it, 50% of the patients with TGFβ2 have had an event by the time they're 40. Whereas if you look at SMAD3, by 40 years old, only 15% of the patients have had an event. So there's a big difference if you have a TGFβ2 versus a SMAD3. When you're 40 years old, your risk for having that aortic event is much higher if you have TGFβ2 than if you have SMAD3. And then let's look again at that childhood onset. If you can look down here, there are no children having events with TGFβ2 or SMAD3. So we have to probably check the aorta when they're children and make sure everything's okay, but we don't really have to be aggressively managing them as children. But you can see that there's a fair number of individuals with TGFBR1 and 2 variants, either TGFBR1 or TGFBR2, that start having events in childhood. And so we need to be much more aggressive in childhood with those particular mutations. And this has big implications for not only preventing bad outcomes, but also in the cost of taking care of these individuals. Like with SMAD3, we don't have to be doing MRIs in children with SMAD3 every 6 months to check the size of their aorta. Where there's a subset of TGFBR2 patients, we have to be doing that. So we have to take the money for taking care of these patients and putting it into in childhood into those children that we have to worry about, and clearly define those that we don't have to worry about during childhood, and concentrate more attention on them later in life. And I'm referring to the SMAD3 patients. But also, if we just take TGFBR2 and ask the question, if we take variants in that gene that we see in multiple people, so, throughout the gene, there's different variants. And if we can get like 10 people with a variant, with one particular variant, we can ask questions about, is there a difference between the age of onset based on what variant you have? And we've done this here. So here you can see that in the orange are all TGFBR2 variants, all other TGFBR2 variants. So these are variants that have occurred in people that we don't have 10 people to look at. But these other variants, like this arginine 258, we have more than 10 individuals with that variant. And you can see right away that these are variants in a child with this variant in a child. We have to be aggressive about repairing that aorta, because they start having events very early in childhood. In fact, that picture of the complete aorta repaired and the other problems with the artery in the TGFBR2 patient, that was a patient with this particular variant. But at the same time, there's other variants where there's not much going on in childhood and much later age of onset. So we don't necessarily have to start being aggressive about imaging these individuals starting at 2-3 years of age, like we do with this variant. So we get so much information from the patients in our study in terms of who we have to treat aggressively, who we don't have to treat aggressively. And it can make such a difference in outcomes and make a difference in how much is the healthcare to take care of these patients. And the same, and also if we just look at patients with TGFBR2, we can see the clinical severity just by looking at them. And over here, we have some patients that were originally described with Loeys-Dietz syndrome that had very widely spaced eyes with craniosynostosis. That's where the skull doesn't fuse properly. So they end up with a very, very widely spaced eyes and an abnormally shaped head. And they can have other birth defects. And these are the kids that have that variant that causes childhood onset. And there's other people with TGFBR2 that look like they have Marfan syndrome, and these can be a little bit later onset. But those ones that have very late onset of their disease look completely normal, and you can't pick them out of a crowd. So in MAC, we're trying to get pictures on everybody so we can actually start using the pictures and the facial appearance to say, oh, we have to worry about really early onset disease in this child, but we don't if they don't have any facial features. We're testing that hypothesis now and applying AI to those facial recognition patterns. And the same is true with the smooth muscle contractile genes. Here's PRKG1 is the earliest onset. ACTA2 is in the middle, and myosin lichen planus is very late onset. only approximately 50% of the individuals have had an event by the age of 70. So this is by far the latest onset disease of any of the genes we've identified. And then again, and this is just to show that by PRKG1 is the earliest onset disease of any of the genes we've identified, and the age of onset is in their late 30s. Average 37 years of age, whereas only 12% of myosin light chain kinase patients have had an event by the age of 37. And 40% have had an event that have ACTA2 mutations. And then if we take ACTA2, we can actually do that same thing that we did with TGFβ2, look at the individual variants and pull out one variant that causes childhood onset, just like that really early onset TGFβ2, and then some variants that cause very late onset disease. And once again, we can translate this into medical practice. And I just want to mention that there's even gender difference, sex differences based on whether you're male or female in how these genes present. Here's TGFβ1 and TGFβ2. So, and this is the onset in men in pink and women in blue. And you can see that men have much earlier onset disease than women when you have a TGFβ1 mutation. But the exact opposite is true with TGFβ2. There's no statistical difference between the male and female curves with TGFβ2. And so even, you know, there can be sex differences with one gene that aren't there at all with another gene. And I want to just give you an example of how this can impact, really significantly impact the care of patients. Here's a family with a PRKG1 mutation. The mother, the pedigree is shown down here, and everybody in the family had the variant that caused thoracic aortic disease, except for the mother. And she had lost her husband at the age of 35 of a dissection. Her first son died of a dissection at 23, and her second son died of a dissection at the age of 18. This individual and this individual did not have any enlargement of their aorta. They didn't have those aneurysms being formed before they had a dissection. So this is a very severe disease in these families. And that's shown over here. This is in pink is the age of onset of dissections, and in blue is the age of onset of aneurysm repair. And you can see the vast majority of people are presenting with those dissections, and many of them die of the type A dissection. So the question was that here was a mother who lost her husband and two sons, and her daughter carried the mutation. I'm not showing the data here, but we have data. There's no sexual differences in between sex differences between males and females with this particular variant. So the girls and young women are at the same risk for having these early onset deadly dissections. And she had a normal aorta, but the decision was made to go ahead and go in and repair her completely normal aorta at the age of 17 to prevent a death like her older brother had just a year earlier. And she's a few years out from that repair and doing very well. So once again, this is an example of how we can do very dramatic management to prevent dissection deaths when we know a gene is so severe and so deadly, and do really unusual methods to make sure we're treating these patients correctly. We cannot treat this family like we do FBN1, where we can watch it grow to 5 centimeters, because none of these people with aneurysms actually grew to 5 centimeters in size. They all dissect with little to no enlargement. So we can also use this information as to inform when we go in and repair the aorta. And for most of the Loeys-Dietz genes, we can't wait until 5. Some we can wait to 5 centimeters, some we can. So I want to get a message across that if you have Loeys-Dietz, you really need to know what mutation, what gene is altered, not just that you have Loeys-Dietz, but whether it's a TGFβ1 or TGFβ2 or SMAD3 alteration, because it makes a difference in terms of the age of onset of aortic events when we go in and repair the aorta, but it also makes a difference in your risk for other aneurysms and dissections and where those other events are. And we're just starting to look at this, at where are patients with Loeys-Dietz, where are they having aneurysm and dissection and ruptures of arteries outside of the aorta. And the good news is actually that arterial ruptures are pretty rare in these patients. And most of them present with a dissection or an aneurysm. And it's not 100% of the patients. It's like about 30% of the patients will go on average to have another problem. So it's not 100% by any means. And it may differ from gene to gene as to where we have to look for those aneurysms. And two things we found out, there's other aneurysms and dissections are more common in women. So there is a sex difference. And number two, smoking increases your risk. So we've had 2 different studies looking at different sets of data in MAC, and both of them pulled out those risks. Please do not smoke anyway, but especially if you have Loeys-Dietz syndrome. And so what we want to do, we want to take everybody at risk for dissections and really figure out how to manage them. So we've got a pretty good handle on Marfan syndrome and Loeys-Dietz, those syndromes. We're starting to understand, families like John Ritter's, where they don't really have any outward manifestations of the disease, but they still have an underlying gene that's mutated it. And so right now we're recruiting for MAC, everybody with a variant in a gene that we've already identified, but we're also recruiting families that are negative for a mutation, because we have to find the rest of those genes. So if you're somebody that has a family history of aortic disease and you yourself have aortic disease, we'd love to have you in our studies to find the rest of the genes. And if you have a gene mutation in FBN1 or Loeys-Dietz genes or ACTA2, we'd love to have you in the Montalcino Aortic Consortium. I'm hoping you understand that how much this data will really help us do that precision medicine and manage everybody. And so this represents about 20% of the people that have an aneurysm or dissection of the aorta, but we know there's a lot of people that don't have a family history, and we really need to go after identifying those genes and how to identify those individuals and prevent those disease. Understand better the other genes that aren't these highly penetrant genes that are highly predictive that you're going to have an event. And the lower risk genes are probably, you get some low risk genetic variant plus some sort of environmental insult, and we know hypertension participates in that, but there's probably a lot of other environmental factors we don't understand yet, and we want to get at all of those. This is Grant Wall, who was the major soccer reporter for the US, who died of an aortic dissection at the World Cup this year. And that was, once again, a tragic death because he had an aortic root aneurysm at the time of his death. So if we had known he was at risk and we're monitoring it, he would have had that aneurysm repaired and would not have died of a type A dissection. And it's still so upsetting to me that it's taking us so long to find all these genes, and I can go into why that is. So we want everybody to be informed of the fact that if they have an aneurysm or an individual in their family with an aneurysm and dissection, it increases the risk for other family members. And there is some new data that will be coming out in circulation that really confirms this using a big Utah database where they have, you know, how everybody's interrelated, and they've used that to really confirm our clinical studies over the years. We recommend genetic testing in anybody that has features aortic disease and features of Marfan syndrome, Loeys-Dietz. And if you have a family history of the disease, whether you have syndromic features or not, if you're young when you have an aortic dissection under the age of 60, we know we can find mutations in 10 or pathogenic variants. And then once the variant is identified in a gene, we go to the gene-based management using that MAC data to dictate how we manage you. And then finally, if you have a family history and the testing's negative, please participate in our research. But then we look at what happened to the family members and base the management on the family members. And so I'm going to stop there. I really want to mention that I do this work with a lot of people in my lab and a lot of collaborators, and I just can't do it without the patients and their families participating. Please let us know if you want to participate by emailing us. And we really thank GADA for their support, along with the NIH, the American Heart Association Foundation, Leduc, and the John Ritter Foundation. And I just want to show you, we had a MAC meeting about a year ago and came up with the research projects that we're pursuing this year. And once again, I'm just so thankful for GADA for supporting this. They really stepped up to help patients worldwide and to understand how to manage these diseases. So thank you. Okay, that's it.
Thank you, Dr. Milewicz. That was such an informative talk. There are several questions, but I think I'll let Andrea go first.
Sorry, I'm just going to share my screen.
Yes.
That didn't work, did it?
So we could see your screen, but it was not in the presenter mode.
There we go. Is it in presenter mode now? Okay, great.
Yes.
So, so thank you to Chrisanne and GADA for asking me to talk, and it's been an honor. So my name is Andrea Rideout. I'm a genetic counselor at the IWK Health Center in Halifax. Some of you may have not met a genetic counselor before, but we are allied health professionals. We have master's degrees specifically in genetics and genetic counseling. And we're not doctors, we don't do physical exams, but a lot of us are involved in counseling and testing people with aortopathy. So I'm lucky enough to be in a large genetics center. We cover all 3 maritime provinces. We have 6 doctors and about 16 genetic counselors. And then we have a smaller team that specializes in aortopathy and connective tissue disorders. So for those of you who don't know, genetic counselors are certified by countries. So we have certification in Canada. And we work in clinical areas like helping patients, research, education, and some of us in industry. So I have a list of questions from Chrisanne that she wanted me to address. So I think Dianna had covered the first one about what is aortopathy. So just quickly, here's our heart. Here's our aorta, the main blood vessel that comes out of the heart. And as healthcare providers, we use a lot of different terms to talk about blood vessels. So I thought I might go through some of them. So dilation means the blood vessel is a larger size than average. Aneurysm is when it's more than 50% larger than normal, and a dissection is a tear. So we're primarily interested in aneurysms in the chest or the thorax because those ones are more likely to be inherited. Abdominal aneurysms are usually more lifestyle factors, so male sex, age, obesity, smoking, etc. And then we've talked a lot about syndromic features. So if we think about some of the pictures Dianna showed, some people have differences in their bone structure or their appearance, which as genetic folks we can recognize, but maybe a layperson wouldn't. And then isolated would have been the picture of John Ritter, who had no syndromic features and was just had aortic problems. So a genetics assessment typically starts before you even show up for your appointment by us collecting and reviewing your medical history. During an appointment, a genetic counselor will take your family history, medical history, give you a risk assessment, either based on your family history. We talk about the risks and benefits of genetic testing. We want to make sure that you have all the information you need to make an informed decision. And our job is really to support you in making a decision that's right for you and your family. We're not the people that have to live with the decisions we make in terms of test results. And then after an appointment, if you decide to have genetic testing, you should receive some documentation that explains what your test results are and what they mean. We typically put that in a letter to you and your doctor. And we can also provide some psychosocial support for people who may be having difficulty adjusting to their test results. So some of the benefits of genetic testing is to identify the cause of your aortopathy. So as Dianna had went through, knowing the cause or the specific gene that has an error in it can change your medical management vastly. It allows us to say, okay, you have this gene error. Now genetic testing is available to all of your family members to determine if they have inherited it. And then I just wanted to put in a plug for those of you who are attending that may have a historical diagnosis of Marfan syndrome. So by historical, I mean they did it by physical exam, they had a checklist and decided if you had enough points to be classified as Marfan syndrome. We are suggesting that those patients show up for genetic testing because there can be lots of differences in overlap of Marfan syndrome, or sorry, lots of overlap between Marfan syndrome and Loeys-Dietz. And so knowing the specific genetic error for yourself can change your medical management. So Loeys-Dietz genes tend to get surgery at a smaller diameter of the aorta than Marfan syndrome. And then for anyone who's concerned about privacy with regard to genetic testing, we have a national law in Canada, or federal law, called GINA, the Genetic Non-Discrimination Act. So essentially your genetic test results are private, cannot be shared with third parties like insurance companies or providers. How is genetic testing done? This is a regular blood test, no fasting required. Typically it's only 1 tube of blood. Depending on what province you live in, you may have other options to do genetic testing via saliva samples, cheek swab, skin biopsy, not a common thing. And we also do genetic testing on autopsy specimens. When we do genetic testing, if you're the first person in the family to be tested, we want to look at as many genes as possible. So for example, depending on which clinic you see, some people may do a targeted panel, so maybe only 20 genes, looking for aneurysms that don't have any features of a syndrome, or if someone has features of a connective tissue disorder, such as differences in their bones or their skin or their eyes, they may want to do a larger panel with more than 50 genes. There's different types of genetic tests. So all the genetic tests we're talking about today are medical tests. So this means that the test is done in a lab that has been certified or accredited to do medical testing, that the results are accurate, and we can use those to change medical management. The most common test we use would be next generation sequencing. So that's a way to look at multiple genes at once for errors. But once the specific error in a family has been found, we do a different type of testing called single gene. We might just be testing for this specific pathogenic variant or mutation in the family, and we wouldn't be looking at other genes. There's been a lot of questions lately about whole exome sequencing, or exome sequencing for short. This is not a routine test for someone with connective tissue disorder. We'd want to go with a panel of genes because it has a better or higher chance of finding a gene error. However, exome sequencing is great for research studies and for people that look like they have more than one genetic condition. Other types of tests are research testing and direct-to-consumer testing, which I'll address. So as we all know in Canada, we have national health care, but really I feel like that's a misnomer. We really have provincial health care. So what test you can access may depend on where you live. So I created this little chart by province for the people who live in the territories like Yukon, Northwest, and Nunavut. Your care can be scrambled between different provinces depending on the situation, but in general, most people from the Northwest Territories go to Alberta, Yukon, BC, and Nunavut to Quebec. So all of the provincial medical centers take all of the provincial medical centers will accept referrals for aortopathy testing. Some cardiac clinics will have a genetic counselor in them, in which case genetic testing is available through the cardiologist, and some heart doctors or cardiologists also have access to genetic testing. So that changes depending on which province you live in, and that is due to the differences in budgets for genetic testing. On the East Coast, we are very, very short on family doctors, so we take self-referrals. And then other provinces will take self-referrals sort of on a case-by-case basis. So for example, in Alberta, you need to have a family history of a genetic condition for them to take a self-referral. And to the best of my knowledge, private pay testing is only available through private clinics. So there's one called MedCan in Toronto, and there are private genetics clinics in Alberta. Oops. And then if you're looking for a genetics clinic, you can go to the Canadian Association of Genetic Counselors website and find a clinic. If you're not sure sort of where to go for genetic testing, you can call the genetics clinic closest to you. They will always have a genetic counselor on call or triage to answer your questions. So don't hesitate to reach out. So this is how genetic testing is done. So from a blood sample, this is the blood cell here, we isolate something called the chromosomes. So we all have 46 chromosomes. They come in pairs of 2, one from mom, one from dad. The chromosomes are made up of this long strand of DNA, and each chunk of DNA is a gene, and each gene is supposed to have a specific function. So if we look at the end of this graphic, we have 4 letters for DNA. T, C, A, G. Those are the spelling, if you will, or sequence of our gene. So when we have genetic testing, we're comparing the person being tested to the expected reference sequence, or you can think of it as a dictionary for that gene. And what we're looking for is there's some difference between the person being tested and what we expect the spelling of the gene to be. And then it gets complicated. There are 3 types of genetic test results. The first one is easy, normal. So they looked at the genes causing aortopathy and they did not find a gene causing the aortopathy. The third one is a mutation or likely pathogenic or pathogenic disease causing. And the third one is called a variant of unknown significance, better known as we don't know. So you might be wondering, why don't we know what's happening with some of the gene changes? So I stole this slide from my colleagues in Alberta. Thanks, guys. If you look at the people on this slide, you can see many differences in hair color, eye color, skin tone, facial structure. All of these are normal gene differences that don't cause disease. So when we're talking about external body features like our appearance, it's pretty easy to see if you have a gene for red hair or brown hair. But when we're talking about genes that make up internal parts of our body, sometimes based on the change of the gene, we can't tell if it's actually going to cause a problem. And we're very careful about that in medicine because we don't want to change someone's healthcare and be wrong. So if you have genetic testing and the test results are normal, we don't have a genetic explanation for why you have the aortic disease. It's important to keep in contact with the genetics clinic because there will be more testing in future. And then your medical management should be based on your own medical history and your imaging studies, as well as your family history. And then for your family members, so first-degree relatives, parents, brothers, sisters, children, they should all have screening for aneurysms. So if you have an aneurysm, your family should be checked. One of the caveats with this testing is that there can still be a gene causing aneurysms in the family, but maybe we can't find it by today's technology. And I won't go over too much of this because Dianna had covered it. The second type of result, we used to call a mutation, and it's now called a likely pathogenic variant or pathogenic variant. So to call something disease causing, we have to reach a level of evidence of at least 90%. But finding a pathogenic gene change means we have found the inherited cause of the aneurysm or the aortopathy. And now genetic testing is available to the family members. We can use this information for things like prenatal diagnosis or pre-implantation genetic diagnosis as well, which I'll explain in a second. And then your medical management should be based on a combination of your medical history, your family history, and your genetic test results. And Dianna had some great examples of the differences between the genes. In every family, there's usually one person that does not want genetic testing. And for that person in the family, they should just continue on with screening because we don't know whether or not they've inherited the gene. So also one of the benefits of finding a gene error is it can tell us whether or not you're at risk for some other health problems with that gene. And many of that Dianna had talked about. So the third result we have is a variant of unknown clinical significance. So this means we found a change in a gene and we're not certain if it's the cause of the aneurysm, maybe because we don't have enough evidence, maybe because you're the only person we can find in the world with it at this time. So we're very careful. We don't want to use it for predictive testing to tell if your family members could be at risk for aneurysms because we're not sure it's actually the cause. So in general, no genetic testing for family members, and all your first-degree relatives should be screened. And most of the genes that Dianna had mentioned are inherited in an autosomal dominant fashion. So in this picture, we have a parent who's red. They have one gene that's working. The dark gene is the one with the error in it. The parent in blue has two normal genes. When we have children, our genetic information is split in half. So we get one set of genes from mom and one from dad. So for this parent, the red parent, there's a 50-50 chance to pass on the gene. So if this child does not inherit the aortopathy gene, they don't need any screening. They don't need to see cardiology, and it doesn't skip a generation, so they can't pass it on to their children. So these people, I guess we would say they're in the clear. Now, for someone who inherits the gene from their parent, what we can say from that genetic test result is they're at higher risk to have an aortic disease or aortopathy or aneurysm, but it's not a crystal ball. We can't say for sure whether they'll have more severe disease than their parent or less severe. We can't predict what age they may need surgery. We can just say they're at higher risk. Although with more data from research, we're definitely being able to define more of what we call the phenotypic information based on genes. So for about a quarter of people who have Marfan syndrome or Loeys-Dietz syndrome, their parents don't have the genetic error. So what happened is the error in the gene occurred at the time of conception by chance. This is a normally occurring event in nature. It's not caused by anything the parents did or did not do. It just happens. But even if your parents don't have the mutation, once you have it, you can still pass it on to your children. So we get lots of questions about this. There's a phenomena in genetics called penetrance. So this means how likely are you to show signs of the disease with a gene error. I think we've covered most of this, but penetrance can be reduced. So not everyone in the family may end up with an aortic aneurysm who has the non-working gene. Some people don't get aneurysms even though they have the non-working gene. So it looks like the condition is skipping a generation. So, but the gene is not skipping a generation. So even if you have the non-working gene, you don't develop an aortic aneurysm, you can still pass it on to your children who can get aortic aneurysms. Hopefully that makes sense. And I just wanted to touch briefly, I mean, we all know that the pandemic has shown how fragile our healthcare system is in Canada, and wait times are atrocious. So a lot of people are turning to what we call direct to consumer testing. So these might be the ads you see on the internet for genetic testing. So we've had a number of people thinking they can help themselves get better care by doing this. And in fact, most of those tests that are available online cannot be used for medical testing, and they're actually not even the same test we would do in a medical lab. For example, I've posted a news article from the New York Times. So a bunch of women in the States did genetic testing to determine their breast cancer risk, and something like 40 to 50% of them got incorrect results. So for example, some women were told they had a breast cancer gene mutation. They went and had surgery to remove their breast and ovaries, and lo and behold, their test results were incorrect, and those surgeries weren't necessary. And then the opposite happened, where people didn't think they had a breast cancer gene and ended up dying of cancer. So there's many pitfalls to this. To try and explain the difference between medical testing and the type of direct consumer testing, which is called GWAS for short, a medical test will give you a very specific result. So I'm using an address as an example. So I'm at the IWK hospital. This would be like my gene. The address is 5850 University Avenue. We've got a city, province, a postal code. So this would be your genetic mutation or your error. And then we can say that I'm going to make up my own disease, IWK related Aortopathy. For direct to consumer testing, they're just looking at common variations in everyone's genome, and they don't look at specific genes or for specific errors for the most part. So it's not a diagnostic test. I understand that can be super confusing. So I think many of us are probably familiar with Google Maps. So a medical test result is going to give you a Google map. So right here is the IWK hospital, the address and everything. So we can use that to find it. A direct-to-consumer result would say, well, the IWK is maybe somewhere in Nova Scotia. So you can't really find the hospital easily with just that vague information. So hopefully that makes sense. Another popular question, family planning. So if you know the specific gene error in the family, you have many options available. You can choose not to get pregnant, adopt children, foster parent, other methods of being parents. Some people with these conditions don't want any testing during pregnancy. Other people say, I need to know because I'll be worried for 9 months. So we have diagnostic testing available as early as 10 weeks through chorionic villus sampling. So that's a test where we insert a tube up through the vagina and remove a piece of the pregnancy sac called villi with suction, and that is tested. Or we can do amniocentesis after 15 weeks, which is a needle through the belly, and we remove 2 tablespoons of the amniotic fluid to test to see whether or not a fetus has inherited a genetic condition. So all those tests are covered by your provincial health care. However, there are private pay options for assisted reproductive technologies. So many people are familiar with IVF. So we take eggs from mom, sperm from dad, we put them in a test tube and fertilization occurs. So you can do that for genetic conditions, and you remove one cell from the developing embryo and you can test for the presence or absence of the genetic condition, and those embryos that don't have it would be transferred back to the mom to hopefully develop into a viable pregnancy. But there are other options such as donor sperm or egg. So some people would rather just use a donor sperm because they don't have, say, Marfan syndrome or whatever. Or some women, given their aortic status, it may not be super safe for them to have a pregnancy. So there is an option of surrogacy. And then just one more plug to participate in MAC or research. We can't provide you with this evidence and this information unless we learn from our patients. So research participation really helps us determine medical management guidelines. It can help us clarify some of those variants of unknown significance. And it really helps other families who may be getting this diagnosis for the first time. And this is the type of information that we use to sort out what's the best treatment option, what's the best timing for surgery? What's the best surgical method? And this will be the information we'll use for maybe gene therapy or other treatments that may be available in future. So sharing your information in an anonymous form for research is great. It may not help you directly immediately, but it'll definitely help other people down the road. And let me tell you, those families really appreciate it when we do have some information to give them about their genetic condition. This is my dog, Joe. So regardless of your circumstances, I think of Joe because you can always overcome, or you can be a rescue dog like Joe, whose owner actually bought him a wheelchair. So thank you.
Thanks so much. Thank you, Andrea, and thank you, Dr. Milewicz, for this really informative discussions, informative information presented. I know we are kind of on the hour, but I'll quickly go through some of the questions, and I appreciate your answers to them. So this one's for Dr. Milewicz. You presented this how gene can dictate the severity of a disease. The different genes can tell you that kind of information. There's a question here asking if it's right to say that people with phenotypic characteristics, are they most likely to have a more serious variant?
Oftentimes they will have a more serious variant, and we have some data to support that, but we're still looking to collect more patients. And then once again, when we start talking about eyes being far apart, not all doctors measure the distance between the eyes. So that's why we want to get those images and be able to really rigorously say, oh, this person does have facial features that are consistent with early onset, and have a computer do it instead of us trying to, because the way, to me, a lot of newborn babies, most of them look dysmorphic to me to begin with. So I want something that's more objective than I am in terms of assessing whether or not a child looks like they have a syndrome or not. So I want to do this in an unbiased way. And so we've got that study launched, and we're actively recruiting, going back to our patients to get facial and side portraits. And we're even working with some of the oral surgeons to how to actually even take pictures inside the mouth, because we all know Marfan patients and many of the Loeys-Dietz patients will have those high arch palates, or the uvula that has, instead of being one prong that comes down, it has two parts to it. So we're working through all that right now. And we hadn't had MAC open to Marfan patients because we knew about Marfan patients, but now we really want to be able to make sure we use Marfan syndrome as like our base to understand other diseases. So we've now opened it to Marfan patients. So if we've turned you away before, now we want you.
Yes, I totally support that. So if someone has a Marfan and is not had genetic testing, it's really important to get genetic testing done and confirm diagnosis, right?
Right. So with if you've been diagnosed with Marfan syndrome, you could actually not have a mutation in the FIN1 and instead have a mutation in one of those Loeys-Dietz syndrome genes, because there's so much overlap. In fact, Loeys-Dietz, when it was first discovered, was actually called Marfan syndrome 2 and not Loeys-Dietz syndrome. And so the only sort of clinical feature that says this is really a FIN1 is if somebody has lens dislocation. So even if you have Marfan syndrome, and especially if you have Marfan syndrome without the lens dislocation, you should think about genetic testing. We have not, since MAC did not recruit Marfan patients initially, we don't have any data to look at variants of Marfans and see if it predicts early onset or late onset disease, but there's been a very large group of Marfan patients in France that have participated in these studies. So the actual underlying variant, we do have data that in FBN1, that variant may be predictive of outcomes too. So.
Thank you. So this is a question regarding genetic testing so this person has 6 aneurysms and has done genetic testing, but it's not come out with any positive gene. And because of the expense of getting genetic testing done repeatedly, has chosen to do ultrasounds or echocardiograms to monitor the remaining 4 aneurysms that he has. So he's just wondering if he should pursue additional testing, and after how long should he pursue additional testing?
So I'm not sure what province you live in, but if you've had 6 aneurysms, you should not be paying for genetic testing. It is covered by the provincial medical system. I know at one point in Alberta, they had a low budget and some people had to pay for certain things, but that has been changed. And then in terms of like how often or when should people look at genes again, if you've had genetic testing and nothing was found, I would suggest you call your genetics clinic or cardiologist to see if there's any new genes available for testing, because we find new genes all the time. Or often enough that it's worth looking at. If you've had genetic testing done and there was a variant of unknown significance identified, again, 2 years is the time to call your genetics department and say, hey, do you have any new information for us? But if you have 6 aneurysms and you're a Canadian citizen, you shouldn't be paying for genetic testing.
Right. So in that respect, there were a couple of questions that came in asking if the genetic test result came negative. Is that also worth pursuing after a few years if the person either has aneurysms and dissections, or if a family or lost a family member to a dissection?
If the person has aneurysms or dissections, you can always, you want to know if the genetic test result was negative or normal, then we want to know what genes were tested and are there new genes that we didn't look at. For some people, it may depend on the test method you have used. They've changed over time and they've gotten better as time passes. So there's a couple different things to think of, but my benchmark is 2 years. Just call the genetics clinic and they can pull your chart and see if there's anything new available.
That's great.
And you don't need a referral for that usually.
Right. Excellent. So Dr. Milewicz, there's one question here asking if families can enter the research themselves, and how do they get enrolled? Do they contact their provider to get enrolled in research?
They can contact us directly to get enrolled. So I put up that email address, and maybe I can put it into the chat. It's in terms of how to get in contact with us. It is jrp.research@uth.tmc.edu, or you can just Google my name and email address and send me an email, and I will
and I
put
think
you in.
That's right. And I think we can follow up with these questions and send the email if there's direct enrollment. And there are questions you're asking if the study would also be interested in COL3A1 gene recruitment.
Oh, yes, we've been recruiting patients with VEDS also.
Right.
And in fact, we've been looking at the Loeys-Dietz versus VEDS patients in terms of, arterial complications, those problems with the artery beyond the aorta. And so, yes, we'd be very interested in recruiting VEDS patients also.
That's great. So another question on the COL genes, is COL5A1 also involved in aortic aneurysms or dissections?
That right now it's not felt to be an aneurysm or dissection gene. We're actually getting ready to publish some new data supporting that it can cause aneurysm and dissections in some individuals. And to
Right.
put that data out there, and it may not be something that immediately gets translated in, but it gives us a chance to have everybody worldwide go back and look at their COL5A1, A2 variants and see if the types of variants we're seeing in our families with aneurysms and dissection match up, so we can start determining if it truly is a gene and get that onto the diagnostic panels. And then once again, trying to figure out which variants cause disease and which variants don't, and how many of that, because COL5A1 and COL5A2 are already known to cause classic Ehlers-Danlos, where there's a lot of loose joints and the loose skin.
Right.
And so we are also collecting all that data to see how much our thoracic aortic disease patients have those phenotypic features also.
Right.
So.
That's wonderful. And so, Dr. Milewicz, can a deceased patient be enrolled by a loved one in the study?
Absolutely, and we need, unfortunately, we need the data on the deceased patients also, because those people tell us a lot about when those aortic events occur and what those events are that cause death. And so we really do need those participants also.
Right. That's great. And so there's this other question regarding genetic counseling, Andrea. So this person lost her son in 2020 to a dissection of the ascending aorta, and the exam of the aorta disclosed abnormalities of its wall, keeping with hypothyroidism or an inheritable disease. And what was identified was a variant of unknown significance in COL3A and FLNA. The person has been recommended for genetic counseling for her daughter. What does this mean?
You're in luck. The medical examiner has my phone number and speed dial, I swear. So in Nova Scotia, anyone who passes away of a dissection gets genetic testing from the medical examiner. And that is true in some other provinces, but I can't tell you on a province by province basis. So the medical examiner is suggesting you get a referral for genetic counseling to talk about what these variants of unknown significance mean in those genes. In some situations, they may want to do what we call segregation studies to see was the collagen 3A1 gene a new change in the person who died? Did either of their parents have it? And where it's a variant of unknown significance, it would be nice to meet with a genetic professional because the medical examiner is not a genetics expert. And maybe we may have access to some information about that specific variant and what it looks like. So for probably no surprise to Canadians, but on the East Coast, we have maps of genetic condition by Bay and Peninsula. And we've been really bad about publishing some of those things because we know they exist and we just don't have time to do it. So yeah, I would suggest going to speak to a genetic counselor about the specific changes that were identified and to see if they're able to tease them out anymore in terms of risk. They can also provide recommendations for screening if you're for a dissection, and make sure you're hooked up with a cardiologist who actually understands all of this stuff and is an expert in managing people with that family history.
Right. Thank you, Andrea. This one I'm going to address it to Dr. Milewicz. So this person says her sons and she has ACTA2 found by your research study in 2008. They've not
Thank
done
you for participating.
Yes, they've not done genetic testing. So her question is now the sons have children age 5 and 2 years. At what age should they have testing done, and what kind of testing would it be for the ACTA2 or a wider panel?
So if it was a variant that was identified in the lab, they do need clinical genetic testing to verify it. My laboratory is a research lab, and we do have our human subject or human research oversight committee lets us report results back, despite the fact we're not a diagnostic lab, because the implications of these results are so important to the family. And so our letter will say, you have this variant, but do not use it at all for testing until you have it validated by or testing or clinical management or anything, until you have it validated by a CLIA certified lab. And that means a lab that goes through all the bells and whistles for clinical testing. And if we did all those bells and whistles, we would have no money left over for research. So we have to be able to do things very quickly, much faster, and much more and more patients than a diagnostic lab needs to do. And so the first thing is to get the clinical testing. And then in terms of the children, we do recommend to go ahead and check the children, but it is the parents' decision. We know that with some of the variants, we have to be aggressive in managing the aortic disease and screening in childhood. And then also, with ACTA2, some of the early onset strokes can occur in childhood. So we really, if they have a variant that predicts the problems with strokes, we definitely need to check those children's early. And if they have it, consider imaging for the cerebral vascular disease, the problems with the arteries in the brain.
Yeah.
And in Canada, we don't have CLIA certification for labs. We have different bodies, just FYI.
Yeah, it's
different name. Yeah.
So.
Yeah, it's going to be a medically accredited lab, which means that they have checks and balances in place to make sure there's no sample mix-up and their equipment's working and all that jazz. So,
right. Thank you. And I know, Dr. Milewicz, you said for people who are interested in joining the research can do it directly. I think it's also possible to do it through a MAC site. So if somebody is a MAC member, Andrea, do you want to address that? If you're a MAC member and how you can enroll patients or patients can approach you?
If you're from the Maritimes, most likely you saw one of the people in my department. You can contact us and we can help you enroll in MAC, or you can use the email address that Dianna provided. And we have ethics approval to do that here. And thankfully GADA, we're getting a virtual research assistant. So thank you to Chris Ann, everyone else to help with that. So
fantastic.
Yes.
And you, Andrea, your group has been fabulous with sending us,
all the weird cases. What is this?
Yeah. So we've got lots of research patients from Halifax, and we're very grateful for that.
You're very welcome. The families are very happy too.
Good.
Yes, I just want to say that we as GADA, we are trying to encourage more Canadian participation in MAC. So hopefully that increases as time goes on. Maybe we can address one last question. So there's a question about ACTA2R212Q. At what age should this grandchildren get tested or get genetic testing for ACTA2R212Q?
I don't remember the specific detail of that particular variant. I'm pretty sure there's no childhood onset events.
Yes.
But I'd have to go back and look at the data. But it's the same sort of thing, is that, there's reasons I didn't mention previously, but if a child does have an ACTA2 variant, not only do we have to check and see if we have to manage it early onset, but also, you want to modify what the child does in terms of sports and so on. Like, we don't want children that have ACTA2 mutations participating in soccer or other sports where they can take a blow to their chest.
Right.
and instead have them doing more running and swimming and things like that. So avoid those and avoiding heavy weightlifting and so on. So it is important to know whether the child has the variant or not.
Right.
So that means no hockey. Sorry, guys.
Oh yeah, I forgot. Hockey's a big thing. Guess what? In Houston, hockey's not that big for kids. But soccer and football are.
Yes. Yes. Thank you so much, Dr. Milewicz and Andrea. I think I could go on with the questions, but I'll put a stop to it. If I know I've not addressed all questions, so if someone has a really pressing question, please, email me, or you can email GADA, and I'll definitely reach out to Dr. Milewicz or to Andrea if it's something specific. I just want to close down by saying that our HAD conference is coming up in June next month. On the 23rd and 24th. The registration is still open for it if anyone's interested in joining. GADA will be there, and our two speakers, Dr. Milewicz and Andrea, will be there as well. And also, if stay connected with GADA. If you have any questions, reach out to us on the GADA email, or stay connected with us through social media. We will have this recording posted on our YouTube channel. As I said, if we didn't get to your questions and it's really pressing, please email me at gadacanada.ca. and we will try and address them through email. Thank you so much. And thank you, Dr. Milewicz. Thank you, Andrea, for your time to talk to us today. And thanks to everyone who attended and sending us your questions to make this webinar worthwhile.